Welcome to the Seeing is Believing Southeast Asia and Western Pacific Regions webinar. My name is Susan Evans and I am the Seeing is Believing Project Officer for IAPB. The theme for this Seeing is Believing webinar is Human Resource Development, and we have some fantastic presentations for you. Thank you all for attending today. I really appreciate you taking the time to join us and be part of our learning community. We've had over 25 people registered from 10 countries in the region, which is fantastic. Also, a big thank you to our webinar presenters. Yuda Sapkota, the IAPB Southeast Asia Regional Coordinator. Wardana Deepa, Senior Project Coordinator, Helen Keller International, Indonesia. Dr. Satya Kotha, the Regional Advisor to iHealth, Asia Pacific Regional Office, Helen Keller International. Dr. Uday R. Gajwala, Superintendent, Tejas Eye Hospital, run by the WPR Trust India. And Harish Kumar, Assistant Manager, Human Resources, Dr. Shroff Charity Eye Hospital, India. So the theme of this Seeing is Believing webinar is Human Resource Development. The presentations today will share successful human resource development strategies from their Seeing is Believing projects, and we hope that webinar participants will be able to identify strategies which could be used in their projects. So I'm now pleased to introduce my colleague, Yuda Sapkota, IAPB Southeast Asia Regional Coordinator, to give an introduction to some of the challenges and opportunities of human resource development in the Southeast Asia region. So Yuda, over to you.
Yeah, thanks, Susan, and good afternoon to everyone. And then first of all, I would like to thanks Seeing is Believing for providing me this opportunity as a panelist. So I'll be mainly talking about kind of the overarching of the Southeast human resource situation in Southeast Asia. Yeah, we all know this human resources is the important factor of all the eye care systems in every country, and then at national, global, and regional and the global level. So there are mainly there are the human resource which is also works behind the scene, like a management experts, and who works in front like a technical peoples. So the main issues here I will be presenting here today in this webinar will be mainly covering the technical parts, like mainly three cadre of the human resource exist to be discussed as an ophthalmologist, optometrist, and allied ophthalmic personnels. Those are the resources, those are the human resource which is very important for the eye care system, and then we do have issues on those kind of human resources in this region. The major issues are first of all, we all say everywhere, that is the number, the adequacy, and then out of them clinically and the surgically active also, and the other issue would be the distribution of them. And another issue with this human resource will be the skill and the productivity. There is skill and the competency, and then of course the productivity are also the issues. And then another factor is a kind of the recognition of their work, their motivation, and the retention are also the issues in many countries in Southeast Asia. So when we talk about the first point, the number, the adequacy, the Southeast Asia region is a little bit better than compared to the sub-Saharan African country in terms of all these three cadre of the human resources. For example, the best country in the region are the Thailand. Thailand has a very good number of ophthalmologists. They have the recent data shows something like 18 ophthalmologists per million populations. And then similarly, another country is the India. India is having a biggest country in the region, the largest population, biggest population in the region, has approximately 20,000 registered ophthalmologists in the country. That makes the 16 ophthalmologists per million populations. Another neighbor country, Pakistan, is also similar, 13 per million. And then the other country like Indonesia, Bhutan, and Nepal shows something like 10 per million ophthalmologists. and the Sri Lanka 9, and the Myanmar 7 per million. And the problems comes to the Timor-Leste, where where there is only one local indigenous ophthalmologist and one expat ophthalmologist working for 1 million populations. So another country like Maldives, where they have, of course, it's a small country. It has only one ophthalmologist, local ophthalmologist, but is heavily saturated by expat ophthalmologists. They have 10. In a way, the Maldives is much well off in terms of the ophthalmologist and the population ratio. So the another issue is the distribution. Another issue is the distributions. Where we could see that all this country, and even the country with a good number of ophthalmologists, the distribution is a problem. 60 to 90% of the ophthalmologists are residing in urban and the major cities. And then when you talk about the bigger country like Indonesia, where the 70% of the ophthalmologists are concentrated only in Java Islands. So Indonesia is the largest country, and then also the many islands, more than 21,000 islands they call it, and then the other peripheral islands, then they have issues on the distributions also. Even they are equal to, in an average, we say the 10 per million, but the distribution is the issue. Another issue would be the skill. Even there are good number of ophthalmologists are there. Their skill are also has been issue in many countries, and the many ophthalmologists who completed that degree, they are still not competent enough to work independently and then perform the cataract surgery. Cataract is being a bigger the leading cause of the blindness and the visual impairment. So we expect every ophthalmologist able to do the cataract surgery with the very much advanced recent technology, but they are not. Those are the issue. And then other issue like motivation and retention in the rural area and the remote area is a issue in every country. It comes to the number and affect to the number and distribution in rural area. And then there are the issues of the recognition of the work also. The problem of the recognition is mainly to the optometrists and allied ophthalmic personnels. So for the country like Bangladesh and Sri Lanka, all allied ophthalmic personnel and optometrist cadre are not recognized. Everything has to be done or recognized to work is an ophthalmologist. So that makes lot affect to the productivity. For example, where the mid-level ophthalmic personnel are recognized to work in a rural area and then do the primary eye care. So those countries' eye care service seems to be better than where the ophthalmologist have to do everything, including from the primary to tertiary level eye care services. Just to give an example, in the Nepal, the optometrists and the ophthalmic assistants are recognized. So therefore, even the number of ophthalmologists is at 10 per million, and then that is approximately 300 ophthalmologists per 30 million population, and then 70% of them are surgically active. That makes approximately 200 ophthalmologists can do approximately 350,000 cataract surgery per year. So that is very good productivity compared to the other country, where in Indonesia, they have a similar ratio of the ophthalmologists to population, where the output and the productivity of the ophthalmologist is very low. Because when we talk about the productivity, the very easy indicators for this to measure is a cataract surgical rate of the country, CSR we call it. So the CSR of the Nepal and India are very good, where the mid-level ophthalmic personnel are recognized to work. For Nepal, close to 5,000, and India over 5,000, where Indonesia is below 2,000. There are many countries where the ophthalmologists are not recognized, their CSR is low. Like, for example, the Bangladesh, the CSR below 2000 also. So these are the issues in the situations in the Southeast Asia eye care human resource situation which need to be addressed. And then in the Southeast Asia region, India is the biggest country, and then where we have a largest eye care service and a lot of center of excellences. And then the best another country is Thailand. Thailand has a very good primary eye care system, good human resources, and then mid-level ophthalmic personnel are also recognized. So those are the examples. And then for the training capacity, India is the one of the best ones. India does trains the bigger number of ophthalmologists, optometrists, and allied ophthalmic personnel. And then in this region, we have Timor, Maldives, and Bhutan. They do not have a indigenous post-graduation training in ophthalmology. And then Bangladesh and Sri Lanka, they do not recognize this mid-level cadre. Therefore, there is not recognized training programs. So the issues here are the already mentioned are the numbers, distribution, skill, and productivity. Productivity is also the one of the issue of the human resources. In Bangladesh, they have a larger number of ophthalmologists, but the productivity very low because of there is no supportive staff for them, and then ophthalmologist has to do everything. So these are the brief, the overarching situation of the human resource in the Southeast Asia region. If there are any specific question on that, I'm ready to answer. Otherwise, I will conclude here. Thank you so much.
Thank you, Yuda. That was a really interesting introduction to the topic, because it's not just about the numbers of the human resources, but it's also about issues like distribution, skill and productivity, and that kind of recognition of work and retention. So really an interesting overview of the complexity of the issues. And interestingly, a lot of these issues that you mention are areas that Seeing is Believing projects are sort of looking into and trying to find solutions to some of these issues. So thank you so much, Yuda. That was a really interesting presentation. Next presentation, I'm going to introduce Donna, the Senior Project Coordinator for Helen Keller International Indonesia. And Donna, I'm going to make you the presenter so we can all see your screen.
Okay, thank you, Ms. Susan. Good afternoon, everyone. I am stationed in the eastern part of Indonesia. My name is Wardana Dipa, working for Helen Keller International, and will present you the Human Resource Development in the Child Eye Health Program in South Sulawesi, Indonesia. So the program design is, the goal of this program is to envision Indonesia where all children with visual impairment and other avoidable eye health condition can be identified early and have access to affordable, qualified services. So the program is a work of consortium consisting of CBM, Fred Hollows Foundation, Orbis International, and the Helen Keller International. We work only in the province of South Sulawesi. This is the eastern part of Indonesia, and each of us is working at a different level. SKA is working mainly at the primary level, and then CBM is working at the tertiary for the low vision training and service, and then Orbis International is working for the secondary and tertiary level, while the Fred Hollows Foundation works in the southern part of this province. As an international NGO, Helen Keller is required to have a work permit from the government of Indonesia. So we had this memorandum of understanding with the ministry, and then the program itself has a memorandum of understanding with the provincial government of South Sulawesi, and then it goes down to the technical agreement with the provincial health office, which enable us to work with various partners such as the university, the hospitals, the district office, and other professional organization. The program did do some sort of a small assessment about the child eye health issue in this province, and there are several things that we found, such as that the primary health center is responsible for all for health status of all babies and students. if you can see the number, one primary health center is responsible for 2 to 39 schools, which means from elementary or kindergarten up to senior high school, and they are to do vision or health screening to the first year students. The number is so big that sometimes not all schools were screened by the primary health center staff. In supporting the human resource in each of the district, the SKI is developing a training model and curriculum, which is we follow the guideline from the Ministry of Health, and then we also propose this to the Ministry of Health for accreditation. By accreditation means that participant for the training can receive a specific number of credit point, which later can be used for their, let's say, for job promotion or to receive another benefit or another training. The program runs a cascaded strategy for developing the human resources in this province. We work we work in the 6th district in 2017 and using this strategy. First, all of this training was not done by SKI itself, but we facilitate this this 3-level training. The first is the district trainer, which they were trained by the Ministry of Health, the Provincial Health Office, and then the Ophthalmologist Association. The district trainers are individuals selected by the district health office, but we gave them some criteria. Like we expect these participants were civil servant because they were less likely they were remain in the position until a pension, and then we also hope that the participant possess health related education, and then also has experience in training or public speaking, and then they also commit to do a training to the primary health center and monitor the subsequent training. These district trainers then return back to their own districts, and they will train the primary health centers. Each of the district trainer is responsible for 4 to 5 primary health center. A primary health center can send about 3 person per unit. So if they are to train 5 centers, then a district trainer means that the district trainer trains about 15 individuals from 5 centers. The staff of these primary health centers will then train school. The program facilitates only 28 schools in each district. So each school can send about 3 teachers per school. And then the primary health center staff also train the community health worker within the district. So last year in 2017, we facilitated around all of the maternal and child health posts within the 6th district. There is also this directive from the Ministry of Health that the primary health center they should do health screening, including the vision screening, to each school within their respective working area. You saw earlier slide that the number was so big that they had to do the vision screening for the first year student almost every day within like 2-3 months in a row. And then also in the primary level, Helen Keller facilitated sensitization to the GP in the primary health center. The GPs is the one responsible for diagnosis, treatment, and referral. By this cascaded training, we expect that the awareness, the information, the skill can reach down to the grassroots level, so that the nearby community can access the primary health center and receive information and receive treatment or be referred to the higher healthcare facility. From the training, in last year, we had reached certain numbers. For the district trainers, we trained 31 individuals from 6 districts, and then these district trainers, they train another 572 for staff from 147 centers. These staff, they train another 521 teachers, and they also sensitize over 6,000 community health worker in the maternal and child health posts. For all of these three trainings and sensitization, we distributed around 9,600 copies of IAC materials. These teachers in school and the cadres in the maternal child health posts, they screen this number of children, 41,000 students in schools, and we also found that around 10% of them failed the screening. And the community health workers, they work with the babies under 5 in the post. So they screen around 85,000 babies, and they refer 200 of the babies to the primary health center for further examination. Like I said earlier, SK is working mainly in the primary level, and Orbis and CBM were doing the secondary and tertiary level. But there is one training that SKI facilitates. It is the training for refraction optician. Actually, we aim for the professional organization, the local organization, so that this refraction optician were sensitized about the program, and then their skills, their knowledge were also upgraded by the expert. The topic was specifically about the pediatric optometry. While at the tertiary and secondary level, Orbis International, they facilitated training for the nurse in district hospital, and also they work on the tertiary level training. What we learned from this from the last year activity was that there was a regulation for the annual health screening, including the vision screening, and then we found that the guideline itself was issued in 2015. But in the field, we found that the primary health center, as the spearhead of this health service, they have never received any training on eye health or vision assessment. So this is the first time they receive a vision assessment training. And also our model to invite the school health teachers for this project, for these activities through the primary healthcare is effective, because the teachers, they meet students every day, so they may notice if there is anything unusual or unusual behavior or anything from the students. So this you can see from the numbers that the teachers, the report we receive from these teachers, so that around 4,000 students failed the visual screening in schools. We also found some challenge that in school any health activities is still considered the responsibility of primary health center. So if there is no visit or communication from the centers, then there is no health screening or vision screening. And then during this screening by the teachers, it takes time, place, energy, and of course support from the headmaster and the colleagues. And since the teacher itself, they have to reach a certain teaching hours. So the screening was done on voluntary basis and on extra hours. Sometimes they have to deal or negotiate with other teachers and use the teaching hours from the other teachers, so they can do vision screening to the students. Further steps that the program would like to do is to provide refraction and optical services to the student who requires eyeglasses, and we also would like to integrate the screening activities in the school, primary health centers, and maternal child health posts, so it is sustainable. Some of the district health office had reported to us that had informed us that some primary health centers within their area are putting some budgets to do the screening to schools, to the maternal child health posts, and the program would like to do to another 18 district in the province. The South Sulawesi has 24 province, so last year we did in 6 districts. This from 2018, and next we would like to replicate these activities to another 18. These whole activities, the project would be good, and would be we would do this. We would achieve that numbers with the support from our partners, the Ministry of Health, the provincial and district health office, the district education office, the National Committee for Prevention of Blindness, and then the professional organizations, the hospital, and then also the university we work with. And also because of this, there's the support from the Standard Chartered Bank and the Seeing is Believing, so we are able to do this project in the 6th district, and hopefully once the agreement is solved, we can work in another 18 districts. I think that's all from me, Ms. Susan.
Thank you, Wardana. That was a really interesting presentation. A couple of real highlights for me around, the fact that there were the regulations and guidelines, that had actually been sort of approved, but that they weren't being implemented and at the primary health level, and that the primary health workers hadn't been trained, and that's a real place where the project can come in and support that, as well as some other really interesting points around getting accreditation for the training modules, so that can be good for individuals, promotions, which is important to all of us, and also training human resources at all levels of the system, all the way from the community to tertiary. So thank you so much. That's a really interesting presentation.
Susan.
Thank you. And just as a reminder, we've actually had a question in already, but we'll save our questions to after all the presentations. But if you do have any questions for the presenters, please do type them in your chat box or the question box, and then I'll ask our presenters at the end. So now, thirdly, I'd like to introduce Dr. Uday Gajwala, the Superintendent Tejas Eye Hospital, run by Devayoti Trust India, and Harish Kumar, the Assistant Manager for Human Resources, Dr. Shroff's Charity Eye Hospital India. And I'm just going to make myself the presenter, and then you'll be able to see my screen. So, Dr. Uday, over to you.
Yeah, good afternoon, everybody. As Mr. Yoda also mentioned, it's difficult to get the technical manpower, particularly in the rural areas. And we are located in a tribal rural area away from the city. Naturally, we had our own set of problems getting the technical manpower. So what we did was we started hiring local young boys and girls, largely from the very poor families. These have dropped out from the schools for whatever reason. Intellectually, they are not at all behind the rest of the students, and it's only that they did not get the opportunity. So we provide them this opportunity to learn eye care, understand the technical aspects. We train them totally free of cost. We provide even the lodging boarding facilities free of cost to these students. But in return, we ask for a 3 years commitment when they complete their training, and we end up paying them better wages as compared to the other employers in the area. However, Better payment is just because we follow all the government regulations, we pay them better wages as compared to the others. Next, please. What we look for in these students while we select them is their willingness to work hard, to learn new skills. That person should not be a troublemaker in the organization. And at times we end up even supporting the family financially during the training period, because sometimes they are the earning members of the family, and if we don't pay them anything, the family will starve. So we even pay them financially for sustenance during the training period. Next, please. In addition to the required benefits, the legal benefits which we are bound to provide because of the legal requirements, we offer them other additional benefits like a life cover under EDLI scheme, personal accident policy that covers them for 24 hours. We support them for mediclaim insurance purpose. We provide them subsidized food in the kitchen, and treatment in the hospital to the staff members and their family is provided free of cost. Medicines whichever are available are given free of cost to the staff and the family members. Next, please. We have a retail outlet for spectacles, and we provide spectacles at a 25% discount to the staff members. In addition to our cost being heavily subsidized, even in the spectacle component. Then there are some staff welfare activities which we undertake, like 2 picnics every year with family in nearby areas. We provide free uniform, books, and notebooks to the school children or the staff members. We have formed a cooperative savings society for the staff members, and loans can be availed and at a very low rate from this savings society, and that encourages saving among the staff members. And whoever is coming from a distance is provided semi-furnished accommodation. That is done even for the staff members. Next, please. Then we provide them next, yeah, career growth opportunities also, in terms of the hospital is committed to train the own staff. Support from Saving is Believing project was used to train staff at all levels of the hospital. This was additional training apart from the technical training that we provided in-house. This training was made possible through the SiB project outside the premises of the hospital in other places. Then we have hired a development trainer also to train staff members, particularly in soft skills, because we realize that apart from the technical skills, soft skills also play a very important role in ensuring patient satisfaction through our services. Next, please. Then some of the examples of career growth in the hospital. 8 entry-level staff members progressed to become technical staff. One young MBA graduate from the town itself is being groomed to take up the post of administrator at a later date. Then one ophthalmic assistant is now in charge of the OPD department and is being prepared to become the OPD manager. These are some of the examples. Next, please. As far as retaining doctors is concerned, we give them free hand for working. We provide them the best state-of-the-art equipments to take care of the patients. We provide them a conducive environment to work. We maintain doctor paramedical ratio of 1:6 so that the doctor's time is saved in diagnostic activities, and it can take care of the surgical work better. We provide remuneration which is close to the government scale to the doctors. We give them a major jump in remuneration if they hang on to us in the third year. If anybody works with us for 5 years, is sent to US for attending academic conference, and the trip is fully sponsored by the organization. Next, please. Then we provide them opportunity to learn the surgical techniques, different surgical techniques, because most of the times when we come out of the postgraduate education program, the practical exposure is very limited, and that's where they learn a lot of surgical techniques after coming and working with us. Then we conduct regular academic meetings for the doctors, so their academic skills are sharpened. We ensure that they attend 2 conferences every year, and these are sponsored by the organization. We give them opportunity to get involved in paper presentations and research activities. We provide them semi-furnished accommodation and subsidized food in the kitchen, the way it's done for the other staff members also. So this has helped us retain the staff members for long periods of time, and the work is progressing very convincingly. So that's all from my side. Thank you for the opportunity. Susan, over to you.
Thank you, Dr. Uday. Thank you for that. And Harish, let me introduce Harish Kumar, who's going to continue with the presentation now.
Yeah, hello everyone. I am Harish Kumar, Assistant Manager HR from Dr. Shroff Charity Eye Hospital. I am based out of Delhi, India. My topic is continued learning and training. Yeah, we have divided continued learning and training at Shroff Hospital into 3 verticals. It is training, mentoring, and continued learning. As far as training is concerned, our aim is to focus on creating resources for the community hospital. So we'll start with doctors vertical. Here we have long-term and short-term training programs, which is focusing on building their super specialty skills in eye. We have an observership program, which is of shorter duration, so that they can observe the latest techniques and procedures in eye care. Next is we have a medical officer program, which is a 2 years program based for next last slide, please. Which is creating a cadre of community ophthalmologists. In this, we absorb fresh ophthalmologists and train them in eye care skills as well as administrative skills. The next category is paramedics, like Dr. Udewala said. We create certified ophthalmic paramedics. These girls are taken from the region where we are operating. We give them a 2 years extensive training in vision technician, ophthalmic nursing assistant, patient educator, that is counseling, and medical record assistants. So once they got the training, they are absorbed into our respective centers as an employee. The third category is optometrists. Here also, similar to doctors, we have long-term and short-term programs catering to their skill development. For non-medical people, we have developed various courses like hospital management course. We have a course for community coordinator also. We do have a course in vision center attendants, where we train them before placing them to the vision centers. Next slide, please. Next slide, please. Yeah, in mentoring verticals, as far as doctors are concerned, we have a credentialing system wherein after every training we credential them so that they get privileging prior to performing a surgery on independently. Then we have various quality monitors which are predefined, and these are monitored on periodic basis. Feedback by mentor and medical education department is one of the key parameters in mentoring. Certification, we do give them certificate once they pass out the course or any skill upgradation training. We have a structured career path when we have a remuneration and other facilities, skill upgradation facilities fixed at every level. As far as paramedics are concerned, we do have the same thing here. We have competency metrics where we train them on the specific skills as per the periodicity of the program. Monthly evaluation by the trainers. Half-yearly exams are there to check their progress. certification at the end of the training of 2 years. Then we do have a structured career path from them also, wherein we absorb the successful candidates once they pass out the program. Optometrists also, we follow the same structure: competency metrics, evaluation by the trainers, half-yearly exam, certification, and structured career path. In non-medical streams, we have well-defined KRAs with well-defined KPIs that is given to the individual in the beginning of the appraisal year, that is a financial year. We have designated central leads for vision centers, community outreach programs to strengthen the vision centers and community outreach across our network. Next slide, please. Continued learning vertical. This is here in we leverage technology and we have used Zoom to have regular interaction with our team members, which are positioned in the different secondary hospitals. We do fortnightly reviews with them over Zoom. We have review mechanism for monthly quality MIS on the predefined parameters over Zoom. We also have half-yearly reviews, wherein we go to the respective centers, sit with them, and share our cross learnings which we had from the other centers. So this is continuous learning using technology and on the ground visits. So here we have some classes wherein we use offline as well as online modes. For doctors, we have weekly classes using Zoom platform wherein we connect all our centers with Delhi. We have sponsored conferences for all our doctors in India as well abroad. We have subspecialty exposure, which we give to them at Delhi and also at their respective centers. Paramedical mix. We also have weekly classes for paramedics using Zoom technology. Similarly, we are doing for optometrists. As far as non-medical stream is concerned, once a week classes by using Zoom platform, wherein we share ideas about building their capacity on eye health programs, community programs. Quarterly workshop on leadership and administrative skills are also planned to improve their skills in these respective areas. That is all. Thank you.
Thank you so much, Harish, and Dr. Uday as well. Some really interesting points came out of that presentation around, firstly we had the rural eye hospital, the rural hospital situation of Tejas Eye Hospital, and some of the ideas around hiring local staff. I love the sort of clarity on staff qualities, what you're looking for to get the right staff for the right places. Really clear on additional benefits and some of those creative ideas for staff retention, as well as really interesting career growth opportunities. And then the comparison with the Dr. Schroff with having the clear resources for each cadre of training that that they're providing, and also with the mentoring too, and the use of Zoom technology for sort of online support is really interesting as well. So thank you both of you for that really fascinating presentation. I think all of our presentations have been really interesting today. So now please do begin. We've got quite a few questions already, so if you do have a question you'd like to ask, please do go ahead. We started a little bit later than planned, so I think we'll continue for a little bit. Obviously, if you have to drop out, do, but I think we can continue for a little bit because I can see we've got quite a lot of questions. But before I go to the questions, I'm going to give the opportunity to my colleague Yuda, who also wants to share some thoughts on staff retention in the region as well. So Yuda, over to you.
Thanks, Susan. Just want to share my experience in the retention of the staff, which briefly mentioned by the Uday and the Harish also. So the major thing in my experience was first of all is the recruitment. So like Uday mentioned, the local people recruitment is a good. Yeah, that's the what we have to do also. We have to think of while recruiting the staff also. It mainly applies for the primary eye care and allied ophthalmic personnel. The recruitment is very important for the retentions. and then we have to see what their expectations, what they want to be in the future is, because our recruitment is not going to be for 1 year or 2 years. We are recruiting them for a longer period, so we have to look at their expectation, and then are we going to fulfill all their expectations within the institute or not? Those are the crucial for the retentions. Another thing is it also applies to the high-level ophthalmic personnel, for ophthalmologists and the other high-level people. It's a growing opportunity, learning, career ladder, all those things has to be also be considered. So that also very important for retentions. And another important factor is the working environment within the institute. That also makes a lot of difference. So if you are putting somebody very trained ophthalmologist in the rural eye center where there is no equipment, instrument, or where there is no adequate facility for him to work, so that also need to be considered, like equipment, instrument, infrastructure, and of course that this kind of people will also like to be very much involved in the academic activities. Also, are those all are available or not? Those also need to be considered. And then, of course, this monetary incentive is a talk at first, but I would talk at last. So the monetary incentive, of course, is important for them to work in a rural and the other area. And then I would also think of the performance-based incentives for it, not only in terms of the money, but also in terms of the further training and the fellowship and attending CPT, CME's continued professional development, I mean, and then the international conference. All those things are also very important for retention the people in a rural area. So those are my experience. And then another, just apart from that, and I just want to grab this opportunity. So we also do have issues of the standard curriculum for the training, because we could see that it mainly applies for the allied ophthalmic personnel. We see that every hospital, every region, or every state, or every country are training. They are training in their own way. Can we have a kind of such a standard curriculum for allied ophthalmic personnel? Because allied ophthalmic personnel means in some places is ophthalmic assistant, some places is vision technician, some places is refractionist, some places is ophthalmic nurses. All these things are just they are trained according to their institutional need. Also, it's very important if we do have a kind of a standard curriculum, an accredited curriculum, and this is recognized by the nations or the national level at the global level. So those would also help for retention of the allied ophthalmic personnel. And even I would think there is no standard curriculum for even the training of the MD ophthalmology. Every university has a bit different kind of things. So that also is a kind of the issue in our region. So the standard training curriculum for maybe high-level training of MD ophthalmology, and then the allied ophthalmic personnel, if we could also work on that, that would be great, and then would help retention and then the quality service delivery. Thank you, Susan.
Thank you, Yuda, for sharing that with us. That's really an interesting perspective as well, to say, some of the areas from your experience really help with retention. And sort of a question challenge to all of us, I suppose, how can we think about aligning the sort of the guidelines and training? So really interesting. Thank you for that. Okay, so I'm going to go to questions now. So again, if you do want to ask a question, please do. For our speakers, I'm going to ask a couple of questions, and then I'll give you the opportunity to respond. So the first question we have from Manfred Morgan, which I think is for the Helen Keller Indonesia project specifically. So it's around what is the perception of the primary health staff about the 0.3% prevalence of eye health problems in children, and do they feel it's worthwhile to invest in the training, etc., given the low prevalence? So that's sort of for Wardana and Satya to respond to. And secondly, we have a question from Yusanasan Nesan, which I think is to all of our presenters, which is around how do you align the newly recruited staff towards the organisational goal? So if we begin with Wardana, and Satya. Do you want to respond to the first question around the sort of the perception of the primary health staff about the low prevalence in eye health of children? And then we'll open it up to everyone for the aligning the newly recruited staff. So, well, Donna, do you want to unmute your microphone? And yeah, great.
Yeah, about the perception of the health office, about the low prevalence.
Exactly.
From our perspective, this is a brand new number for them. Indonesia, as far as we know, Indonesia has never had any data about the child eye health. So this is the first number, I guess, for the government. At this point, what we know is that the consortium is the only one working for the child eye health. So the others, the ministry, the national committee, they are working. They're focusing to cataract. So I think we are providing a complementary information for them that not just cataract, the government and the other stakeholder has to focus, but also they have to focus about the child eye health. So they about the number of about the 31%, they were not that surprised. They were not really surprised. But the school, the percentage from the school screening, they were quite surprised. And there were cases that we told them in the meetings and the workshop. They were surprised that children were unable to access the refraction surface. They were surprised that some children already had this problem that they cannot see the first letter in the chart, in the Snellen chart. They were surprised to this reality, to this fact. Yeah, that's from my side. Dr. Satya, if you like to add.
Dr. Satya, do you want to unmute your microphone, and also if there's anything you've got to add to that? Dr. Satya, we're not hearing you. I think you just need to unmute your microphone. Okay. We don't have Dr. Satya at the moment, no problem. But yes, I think that's a really important point, the importance of data in terms of using that for advocacy and letting people know the scale of the issue. And also from the teacher's perspective, if you know that your class, you're talking about quality education now as being a big thing. And if your children aren't able to see the blackboard, then the quality of education you're providing is important. And a comment from Yuda actually around prevalence of childhood blindness is low, but visual impairment and other ocular morbidity in children is high. So there are some really interesting points there. Thank you. So now the second question then, which I think Donna will come back to you as well, which is around how do you align the newly recruited staff to the organizational goal? So if we start with you, and then we'll go to Dr. Uday and Harish.
Okay, I think this question is more about how we recruit our own staff. Yeah, if I can understand that correctly. So yeah, there isn't many people or individuals working in this child eye health area. Even for me, I was very new about eye health issues. So Dr. Satya trained me, and there was another college. We started as a team of 3, and then expanded until now we are a team of 7. So Dr. Satya, as our supervisor, the manager, she provides us information, background. She briefs us regularly, and she gave us articles and all, and also that we also need to understand the health system in Indonesia, and how me and my colleagues, we understand the health system and where the regulations are, what the staff should do, and then we align that with our project. Then we forward that information. We brief our team. Then the rest of the team were briefed by us, monitored by Dr. Satya. So we are still learning about this complexity of this issue, but we are still trying to give a perspective that even though child eye health is a small issue, is maybe some or most people thinks this is simple, something not really important, but this is an infestation, an infestation not just for the government, but for us as individual, as a parents, as an uncle for someone, that we do need to think about the quality life that our children should have. Some of our colleagues here, they once they know this and understand the issue, work within the issue, they saw themselves that they have this nephew who has this problem and they were not able to access this, were unable to. They bought some glasses and they couldn't understand why this glasses is not good. It didn't support them to see, so things are starting to grow and we learn from each other. That's how we here in Helen Keller does our strengthening, our empowerment for the staff, for our internal one. But for the partners, we do discuss, we forward them articles. We have some promising response, some replication from an independent replication funded by their own budget from some district government, and that's good to hear that they're focusing on this issue and they think this is important as the education itself is maintaining the health of these children.
Thank you. Yeah, no, it is that whichever organisation, whether you're talking about the NGO or the hospital, I think a lot of it is around that that awareness of the importance of the issue. So thank you for that. Okay, so the same question around how do you align the newly recruited staff towards your organisational goal, maybe thinking about some of the staff you've trained. I'm going to say, Dr. Uday, do you want to please answer this question from your perspective?
Well, yes, it's a very important question. All the staff who are newly recruited have to undergo an induction program in the organization. And in our place, the induction lasts for about 15 days, where we try to show them how we are doing things, why we are doing things in one particular way, why the organization, the vision and mission. And so the HR department has to really groom them to understand the vision, mission, and the culture of the organization so that they can work in tandem with the rest of the staff members in the organization. It's a very, very important activity to our mind. So that's how we take care of that. And the question before that was not meant for me. The childhood blindness percentage is very low, but the children live many years. So in India, the total blind years spent by the children will almost come to very close to what the adults live with the blindness. And that's why this is very important and should be tackled even if the percentages are low. Thank you.
Thank you. Yeah, that's a really interesting argument, actually, and a good way of emphasising the importance of child eye health as well. And thank you for explaining around that induction is so important in terms of aligning people with organisational goals. Okay, Harish, so thank you for that, Dr. Uday. So Harish, over to you now.
Thank you. Thing is, we do have a structured program like this that Sir said. We have an induction program wherein we inculcate values, goals, vision and mission of our organization into the new recruits so that they come into alignment with our policies and long-term goal and objectives. So we do it at Delhi. We invite all of our new joinees across all the centers to Delhi, and we have a structured program here at Delhi, our tertiary care hospital, wherein we give them training, imparting these skills so that they becomes aligned to our long-term objective. So this is we we are doing at present, and we are doing for all the cadre of the employees, whether they are junior most to doctors. We follow the same process.
Great, great, thank you. Thanks, Harish, that's really interesting. Okay, Dr. Satya, do you have anything to add, or Yuda, anything to add on those questions?
No, not really. I already mentioned a bit about the kind of the during the recruitment, the organization objective, and then the person's expectation should be aligned. So that was the things need to be evaluated while recruiting, and then of course during the induction program. Thanks.
Yes, exactly. That recruitment and expectation is really important at that early stage. Okay, so we've just got a sorry, is someone else speaking? So please, Harish.
Sorry.
Oh, okay, yeah, okay. So just a couple of final questions then, before we round up for today. So I have a question from Anil Gorkali, which is, I think, to all of our presenters, which is around, are your doctors allowed to do private practice, and does that have any sort of influence, I think, on the performance? And also, secondly, from Lan Luong, which says, who's saying, what kind of training do you provide to the local boys and girls, or sort of your trainees, and what educational conditions do they need to be qualified to be accepted in the training? And I think that's probably, that second one is, I think, more towards the TAES Eye Hospital, but I think it's also relevant for all. So if you sort of can address those two questions. So again, I'll start with Wardana, around the doctors within the project. Are they allowed to do the private practice? And then what kind of training and educational conditions are needed? So Wardana.
Yeah, sorry, I don't really catch the question. What kind of training we provide? Hello? Hello, Ms. Susan?
Sorry, I'd muted myself. Okay. The first question was around, are doctors allowed to do private practice, the doctors within the project? And the second one was around, I think it's probably more for TAES Eye Hospital, which is around what they talked about, the training for the local young boys and girls. So maybe we'll leave that one for Dr. Uday. But I suppose the first one is the doctors. This question around the doctors doing the private practice, and does that impact on the program at all?
Yeah, we didn't monitor that. The private practice, but here in our working area, there isn't much private practice here. In Makassar is the largest city here in this province, so we noticed that there are another private clinic, like 2 or 3, but we didn't work with the private clinics because those ophthalmologists that we work with, they are also the one that we work with in the public hospitals and in the professional organizations. So we reached out to the professional organization and the public hospital, the government hospital. So our program wasn't designed to reach out the private clinics. So I don't think that I cannot give you the answer if it affects us, but because if these are all the same ophthalmologists, so it may it may affect and somehow, but we didn't monitor that impact. Yeah.
Sure, thank you. Okay, then the question for Dr. Uday then, I think specifically, which is around what's the kind of the training that you provide when you employ your local staff. You sort of you mentioned that you provide training to local young boys and girls. What kind of training do you provide as the basic level, and what are the educational conditions that they need to be accepted in the training?
Yes, the educational qualification for being accepted in the training is 10+2. But at times we've relaxed this criteria when we find that the boy or the girl is very needy and the intellectual levels are good enough. See, as I said, they have dropped out of the school for several reasons, not because they are mentally poor, and that is where we tend to relax, but that's occasionally done. By and large, they are 10 plus 2. We give them a 1 year training. The cadre is called Vision Technician, and this Vision Technician training is being run in India in I would believe around half a dozen places, and the curriculum is very well standardized. So we run this 1 year certificate course, and the certificate is under Skill India program. So that works well for the students also when they go out and want to work with the private practitioner or with the other NGO in the area. This certificate really helps them. Though this is not a degree or a qualification from the university, but as Government of India has announced, this is Skill India program, and this certificate works well for the students. Thank you.
Great, thank you. And the question around from Anil Gorkali, which is around the doctors allowed to do private practice at the same time. It's also for Dr. Uday and Harish.
In our place, we do not allow private practice to the full-time ophthalmologists who work with us. But right on the other hand, we are in a very remote place, so they don't have even the opportunity to do the private practice in the evening hours, even if they are free. It's a very small town we're working. The population is only 25,000. So, but
Sure.
in any case, we don't allow them private practice.
Okay, thank you. And then finally, Harish, the same question to you about the.
Actually, at Shroff, we also have the similar policy. We don't allow doctors to work somewhere else during their association with our organization. So they are full-time, all are full-time employees. We don't have part-time or like few days kind of structure in the organization.
Great, thank you. And then I think Yuda's got a comment about the Nepal experience with private practice. So Yuda?
Yeah, in the Nepal, there are two organizations mainly provides the eye care services. One is the Nepal Netra Jyotishang and the Tilganga Institute of Ophthalmology. So the Netra Jyotishang works all the rural area, and then they don't allow private practice. In the rural area, as mentioned earlier, the private practice will not be very rewarding also. They are not very beneficial also. So they are provided with the kind of the practice compensation and then posted to the rural area. That's the strategy NHS has taken. And then Tilganga works also in the city, in the big city hospital, where the doctors, ophthalmologists will have a better opportunity, better chance of getting a good practice. So there they have adopted a strategy that they should do the private practice in the hospital in the afternoon. So that by 3 o'clock in the afternoon, all the general patients are completed, and 3 to 6 o'clock, the private doctor can start private practice, in which 50% goes income goes to the doctor, 20% goes to the support staff, and 30% goes to the hospital. Those are the strategy adopted. But both organizations, they don't allow like others to do the private practice in other or to work in other places. Thanks.
Oh, that's interesting. So they manage it, they sort of control it really. Yeah, no, that's interesting. It's good to have the sort of the overview of the different approaches. Thank you for that, Yuda. Okay, so they're all of our questions, and we've managed to get Dr. Satya back online as well. So I'm just going to hand over to Dr. Satya now as well to see if she's got any sort of final thoughts or any kind of points that she wanted to make as well. So Dr. Satya, if you're able to unmute your microphone now, you can just give us any sort of final thoughts from your side as well. It says that you're self-muted, so you just need to click on the little microphone circle. I'm not able to unmute you. So there should just be like a little the round button with the microphone on. It should be, I think, orange. So if you just click on it, then you'll be able to unmute yourself just in the control panel. It says you're muted by me. Okay. No, it says that you're self-muted. Sorry, bear with us. Sorry, Satya. It says that you're self-muted, so I'm not able to unmute you, which is really unfortunate. I'm wondering if my colleague Saloni can help me. It says attendee is self-muted and muted by an organizer.
If I can help, I think yeah, I can unmute her. I just unmuted her. Satya, can you hear us?
Yes, I can hear you clearly all the while. I can't speak out.
Lovely.
Yeah, I can.
Thank you, Saloni, for coming to our rescue. So, Dr. Satya, over to you for your sort of final thoughts.
Yeah. So a couple of, I think Deepa has answered all the questions suitably. From my side, it's just about the perception of the health staff having known that the prevalence is only 0.3% of child eye health. I think the world over, I think it's expected that the child eye health problems are usually very low. The prevalence is not very high, but it's the total number of blind years that the child has to live through, and that's the thing that's more important in considering why child eye health should be a part of should be prioritized in visual impairment. So and just to go back to the training, the sensitization that's given to the community health workers is only a 2-hour sensitization. So it's not a complete training package that would be given. At the maternal and child health post, the healthcare volunteers are supervised by a midwife, and they usually provide immunizations. They do body weight and the head circumference and make sure the nutrition is good, and also they try to encourage breastfeeding in that situation in the maternal and child health post. So by screening, we only ask them to look for any obvious health conditions, eye health conditions in the babies, if they have an obvious squint, or if they are not following light, or if they have a red eye or a sticky eye. That's when we encourage them to refer the child to the primary health center from the community health post. So this training is very minimal, and for these health volunteers, they're actually they love to do this kind of thing because they feel that they have gained more knowledge and they can help their community in providing this service to them. So they are very enthusiastic during all these trainings. So they don't really think that the prevalence is very low, and they don't think it's worth their while to attend the training. That much about the perception of the health staff. The private practitioners, as Deepa said, that Indonesia, the system is not like in India, where there is a very strong private platform to provide eye health services. In Indonesia, the government system is very strong. Whatever is there is the government health system. So when all our projects are aligned to what the government is doing, training is within the government system, the service delivery is within the government system. So strengthening any area is within the government system. So private practitioners are prevalent, and these the same doctors who work in public hospitals also work in their private clinics, but they go there only after 3 o'clock, after they finish seeing all the patients in their clinic in the hospital. So it has never been considered here as a taboo, or as a barrier for service delivery for private practitioners. I think that's all I wanted to add on to what Deepa had already talked. So.
Wonderful. Thank you, Dr. Satya. Yes, it's a really interesting, again, a way of embedding it within the system, you know, working with the midwives and maternal and child eye health, because obviously they're looking at the children anyway. So it's just like an extra thing, embedding it within that kind of system. And really interesting about talking about the different, you know, the fact that the government health structure is sort of the main provider in Indonesia. And so that's sort of how, you know, that's why you're sort of supporting that system and that route through as well. Again, like a different, you know, different sort of system, and that's interesting to think about that in comparison to the, you know, the Nepal and the India context as well. So thank you. I think that we should probably end it there. We're a little bit over time, but I think it's worth it to get everyone the opportunity to ask the questions that they wanted to. And thank you to everyone for sort of staying to this sort of the end as well. So I would like to just end by thanking our presenters, Yuda, Wardana, Dr. Satya, Dr. Uday, and Harish for their comprehensive presentations and responses to all the questions. Thank you, Saloni, for all your technical support. And thank you to everyone who's participated. I really appreciate you taking the time to be part of our Seeing is Believing learning community.